Thank you very much, and thank you for inviting me to speak today. It's a real pleasure to come here and to talk to you. As mentioned, my name is Delan. Devakumar, and I'm going to talk to you about racism and xenophobia to give a broad public health perspective, largely a global health perspective, and sometimes a political perspective on these issues, and talk mostly about the Lancet series on racism, xenophobia, discrimination, with a few other bits and pieces in between. So racism, xenophobia, other forms of discrimination are fundamental determinants of health. They impact the health, illness, mortality of people around the world. And what I was hoping to do with this series was these three key aims, was to get wider recognition of these issues within contexts such as this, academic settings and also clinical settings, for clinicians to think about these issues when they're speaking to patients, to think about them on a global health perspective. There are similar things happening around the world based on someone's identity, on their caste or religion or indigenous status, amongst other things. And to focus on the structural causes, we think about individual acts of verbal abuse, physical abuse, but most of that, there's an underlying structural cause which leads to the outcomes that we might see. So this work stemmed from the Lancet Commission on Migration and Health, and this was published in December 2018. And within that commission, there was growing awareness of the problems of xenophobia towards migrants, the barriers towards achieving the optimum health for migrants. And in this commission, we tried to tackle some of the myths around migrant health. The fact that migrants are disease carriers that pose risks to populations. And you hear this around the world. You hear this, President Donald Trump would talk about Mexicans or Latino people coming across the border, bringing diseases and illnesses to the population. So within this commission, we sought to challenge these xenophobic types of rhetoric, to look at the evidence, to look at the facts behind this, and to show that actually migrants are more at risk of becoming unwell themselves, but not at risk of passing on disease to the local population. So then in 2019, I started to work on this particular series. And at the start, no one really cared about this. No one really thought about this. But then in 2020, lots of things changed. And we had the COVID-19 pandemic, of course, and particularly early on in the pandemic, we saw physical and verbal violence towards people of East Asian origin. We saw these types of images of people being shunned at borders, exclusion criteria based on someone's health. And then, of course, the murder of George Floyd and the following Black Lives Matter movement protests, which happened predominantly in the US, but around the world. This is about how, but this isn't just about individual mortality, individual acts of violence or murder. This is about how racism runs through societies, the fundamental and deeply rooted systems of oppression that result in the deaths of innocent people. And COVID-19 was a very good example of how racism can play out. And we saw these differences in mortality. So this is the ONS data from January 2020 to 21. And if you look at the mortality differences, we see that Bangladeshi women are at a 4 times increased risk of dying from COVID-19 compared to white women in the UK. Bangladeshi men have 5 times increased risk of dying. So racism has a profound effect. People are dying based on their ethnicity, and this is in the UK. So why does this happen? Well, there are multiple causes, and there are individual causes and structural causes. People from Black, Asian, minority ethnic groups are more likely to get infected in the first place. We see that Black people are more likely to work in healthcare settings. Pakistani, Bangladeshi people more likely to work in the service industry, to be at the front line, more likely to come in contact with infections. They're more likely to live in overcrowded forms of accommodation, so to pass infection on from person to person. And then they're more likely to have underlying illnesses, non-communicable diseases that put them at increased risk of mortality, morbidity. And also, there are these barriers to accessing the health system. that affect migrant groups, amongst many others within the UK. So it could be these cultural barriers where people don't understand the health system, don't know how to seek help, don't know where to go. And we're seeing this in terms of vaccine rollout as well, and how certain groups have high rates of vaccine uptake compared to other groups. So what is racism? There are many definitions of racism, and these are our definitions that we included within the series. So we took quite a broad view of what racism is, that it's an organized system that affords power and privilege according to an established hierarchy based on racial categories. And racism gives power, rights, protection to those at the top of this hierarchy. We see similar kinds of processes going on with other things like ethnicity, with the caste system, with indigenous people compared to non-indigenous people. Xenophobia is very similar, but it's about those who are considered to be foreigners. And there's a lot of overlap usually between racism and xenophobia, and it's often difficult to know which one is exactly at play. There could be examples of just xenophobia towards any foreigner, but often that's overlaid with racism as well. And then discrimination. So this is differential treatment or outcomes that are unfavorable towards a certain group or individual based on some aspect of their identity. So in its most basic and fundamental form, for racism to exist requires racial categorization. And this goes back to the 1700s, to Blumenbach and to Linnaeus. These ideas of colours that we still talk about today, white and black most commonly. But then Linnaeus took this one step further to attach characteristics to people from those groups. The Americanus being obstinate or merry, Asiaticus melancholy, haughty, Africanus relaxed, without shame, crafty, indolent. And of course, the European sanguine, muscular, inventive. They put themselves at the top of this hierarchy and placed others below it. And it's important to remember that these are social categorizations. These aren't based on biological studies, or in those days there weren't genetic studies. So these are socially categorized based on the opinions of these people in Europe. And this has led on to some of the worst forms of actions that we see today. And it's not just the acts of genocide or Joseph Mengele within the Nazi regime. We see this much more fundamentally in the actions that are within the scientific community, within the medical community. So eugenics being one example of that. And I stand here as a professor in UCL that was quite central to the scientific basis of the eugenics movement under Francis Galton and Carl Pearson after him. So according to Galton, eugenics deals with what is more valuable than money or lands, namely the heritage of high character, capable brains, fine physique and vigor. It aims at the evolution and preservation of high races of men. Of course, those high races of men were people who looked like Galton. Eugenics essentially divided people into two groups, those who are worthy to give life and those who are not. And this is still played out today. We see, this is the inquiry into the history of eugenics at UCL, a quote, that around the world, eugenics of one form or another is implicated in compulsory sterilization. Think about the Mississippi appendectomy that went on to mid to late 20th century within the US, the forced sterilization of Black women. The legislation on mental deficiency, immigration law and racist policies, the notion of natural intelligence, the normalization of segregation by race, ability, and class. So these things are still implicated into the actions that we take today. Some of the policies that we see today are still based on these kinds of notions. And maybe most famously was the Tuskegee study of untreated syphilis in the Negro male, 1932 to 72. So this, you may know this already, quite famous study within the US. They wanted to look at the natural history of syphilis, and they took 600 Black men, about 2/3 with syphilis, without proper informed consent. And I think that's fundamental. These people didn't know what they were signing up to. They were told they were being treated for bad blood, this local term that described many different ailments. They received free medical exams, free meals, burial insurance. But fundamentally, from 1947, when penicillin was the recommended drug of choice for syphilis, these men were not treated. So from 47 up to 72, when the study finished, they were still not treated for syphilis. And of course, syphilis being an infectious disease, this was passed on to some of their wives, children born with congenital syphilis. And this, I mean, on the plus side, this prompted changes to ethics, to scientific oversight and governance within the US and around the world. So within the series, we try to look at a very broad way at racism and how it leads to ill health. So we started to build up this conceptual model looking at the individual person down to the more structural causes. So starting with the individual, there are these behavioral, psychological, physiological consequences that result from racism, from xenophobia, different kinds of discrimination. And you can see that across the life stages, so from birth to childhood, to adults and to older people, and then also intergenerationally, we see these consequences passing on to the children of the adults. We summarize the different kinds of health outcomes that are related to racism and discrimination. And there's too many to go through in any detail here, but just to say there are a lot of them. And at every life stage, there are a lot of different health outcomes that result from racism. And this is both interpersonal and structural, and I'll come on to the different pathways, how that may play out. So my colleague Ian Paradis, he did a systematic review of articles, this was in 2015, that looked at racism and health outcomes. And they found 330 articles, 33 articles. About 80% of these are from the US. So the literature is very dominated by the US. If we add in UK, Australia, Canada, I think that goes to over 90%. So there's, I think there were no studies from low middle income countries that they found in this systematic review, meta-analysis. And what they showed was that there was an association between poorer racism and poorer mental health, depression, anxiety, psychological stress. That was stronger in Asian Americans and Latina Americans. There was an association with general and physical health, against stronger in Latina people, not moderated by age, sex, or birthplace. So Yin, Paradis, and others looked at the ways that this may happen, and they described these different pathways. If we think of the most obvious, the assault pathway on the bottom, the physical injuries that result from attacks. If we think of George Floyd as an example, a racist attack on a black man. So that's the thing that people might think of when they think of racism, these types of pathways. There's then the more structural causes. I'll come on to how this plays out in the UK in terms of migration, but we talk about the denial of services, denial of resources towards people of certain identities. And then these other psychological stress-related responses of how there can be overregulation of the neuroendocrine system. This idea of allostatic load, where there's chronic stress and overload of organs within the body that leads to this concept of toxic stress, prolonged elevation and activation of neuroendocrine responses that leads to physical as well as hormonal imbalances, particularly cortisol, noradrenaline, and adrenaline, which leads to these differences in the prevalence of diseases, particularly mental health illnesses, but also physical health related to the immune system, to epigenetic changes, so changes that result in differences in telomere shortening. So telomeres being the cap on chromosomes that are a kind of biological marker of aging. So we see differences in telomere length between different ethnic groups related to racism. So then my next step was to look at how those individuals live within communities. So communities can protect individuals from the consequences of racism, and they can also lead to the consequences of racism as well. And these communities could be physical communities where people live, or also dispersed communities around the world with increased social media and interactions between people. We put this model in the world, so this mimic the world in this conceptual model. So then we thought about the spaces that people live in, the environments that people live in. We think about air pollution, for example, and if we look at London, people from minority ethnic groups are more likely to breathe poorer air of poorer quality, increased particle mass, increased noxious fumes. There was the tragic death of Enikisi Debro, and it was the first time that air pollution and, in fact, a form of environmental racism was included within the death certificates of this person. And Rosamund has started a new foundation, so looking particularly at air pollution within London and within urban settings. We've got a paper coming out in a few weeks that looks at climate change and racial justice. And in this, we reviewed the studies looking at racially minoritized groups, migrants, indigenous communities. We found that those communities are much more vulnerable to climate-related impacts and face a disproportionate burden of morbidity and mortality going forward. And these are communities that have contributed very little. If we look at the impact of countries from the global north compared to the global south, the global north comprising just 14% of the world's population, we see that they're responsible for 92% of historical carbon dioxide emissions. That's in excess of planetary boundaries. So each country has a kind of planetary boundary, and all of these richer countries have exceeded those boundaries. And the vast majority of global south countries, including some of the biggest, most populous countries in the world, are well within their planetary boundary limits. When we see this, we think about the protections that people have. What effect will climate change have on the UK compared to some of the poorest parts of the world and the poorest populations in the world? We then wanted to look at the kind of underlying causes of ill health. And we looked at these structural causes that lead to the consequences that we see. And we described these two concepts of hierarchy and separation. So these structural forms of discrimination, these processes that lead out to the health consequences we see. And the first part of that is separation, so dividing populations into different groups. And you see this everywhere. You see this within sports teams, for example, and sometimes that division is innocuous. But then it's the addition of the hierarchy, that certain groups are above other groups. We think back to the racial categories we saw before, that white Europeans were put at the top of this hierarchy and other groups were below them. And this leads to those at the top having privileged capabilities, capital, financial capital, racial capital, the economic and social value that's extracted on the basis of someone's racial identity. And we see these kinds of concepts ingrained into laws. Most famously, apartheid laws within South Africa. There's Jim Crow laws within the US, the redlining and separation of racial groups within the US. We see this as a basis for colonization, how those people over there were thought to be less, to be a lower level compared to the people here, which makes it easier for the idea of colonization to go there and to take things from those people, to take those people to other places as slaves. And again, these structural causes are still here present today. So a study we looked at undocumented migrant children in the UK. So to be undocumented is to not have the documentation required for regular immigration status. And there are 120,000 children with undocumented status in the UK, around half of whom were actually born in the UK, but their parents have an undocumented status. So those children are there's a requirement for charging for secondary care in the UK that's higher than the normal tariff, 150% of the NHS tariff. And any debts that are over a certain amount can be referred to the Home Office. So what happens in the UK? We see that these children, their parents may rightfully be concerned about taking their child to the hospital. We see delays in treatment for illnesses that children should be treated for. I think there's also confusion. It's not known who can be treated, who can't be treated, for what can they be treated. Primary care is not charged, but secondary care is. We see the newborns and antenatal care is charged. Average cost is £6,000 per delivery. We see safeguarding issues, children who are trafficked are not charged, but often you don't know who's trafficked and who isn't trafficked. And even the system of trying to find those people who should be charged is, not very well set up. I remember receiving a letter myself. My son was born in the UK, shouldn't have been charged, but I received a letter, I think only because of my name, asking whether we should pay this secondary care fee for him. So within the structural causes and the individuals and communities, there are the systems, there are the institutions, and we separated out the health system here, by which these policies, these laws, these attitudes sometimes can lead to health consequences. We then map the different ways in which racism can lead to poor health. There are deliberate causes. I'm sure there could be deliberate acts of racism towards patients, towards health workers and staff. But a lot of this is not deliberate, and it's about how the system can be set up. It's about unconscious forms of bias. It's about systems of charging, as I discussed before, accessibility. It's about cultural barriers in terms of language, for example, about who is able to access this health system and who is excluded from the health system. It could be lack of interpreters, it could be staff shortages, could be the progression of staff through the system. We see differences in progression amongst ethnic groups within medical staff in the UK, with certain groups doing better with exams, progressing faster through the hierarchy than other groups. As you might assume, white people tend to do best within progression through exams, black people tend to do worst through exam progression. And these are people who are trained in the UK, so have the same education system. If we think about barriers to entry, so going back to migrants, so migrants, there's a right to the highest attainable standard of health for all individuals, so that's not based on someone's migratory status. But increasingly, countries are using health restrictions as barriers, as I started to talk about at the start of this presentation. And these are not permissible by international law or by human rights law. And countries would do better if they integrated migrants within the health system. And this is most obviously played out in the COVID-19 pandemic, where excluding a group makes no sense at all. But because these barriers are in place, the people themselves may fear going to the health system, may fear deportation based on their immigration status. So these structural barriers are leading to the ill health of people, which has knock-on effects for the local population as well. So finally, we looked at the life course perspective. So we put this ring around our model. So to think about how racism, xenophobia, discrimination affects people at different stages of life. And then we thought about the intersecting systems of oppression, which I'll come on to in a moment. So what we did in this conceptual model is to try and flip around the usual social ecological model that you might see, where the person is at the center and there are other rings outside. Here we put the persons very small on the outside, and really the structural causes of the reasons that that person becomes unwell, that person has higher rate of mortality, as we saw in COVID-19. So we then looked at intersectionality and how people lead multiple lives, have many different identities at the same time. So to look at one aspect misses all aspects of their life. So in this paper, we took case studies from around the world, and we looked at different kinds of discrimination, different kinds of oppression, and looked at similarities and differences between them, and commonalities that those forms of oppression may lead to health outcomes. So we had 5 case studies from around the world, and we're looking at commonalities. We see that history, the colonial history in particular, can shape these contemporary experiences. So these case studies were from Australia, from Brazil, South Africa. There's one covering Europe and North America, and India as well. And ideas of separation and hierarchy, as I described, these lines of identity, different types of identity. It could be someone's indigenous status, migratory status, caste being an issue within the Indian subcontinent. The visibility, the fact that certain identities are visible. This one in particular was looking at Muslim people and how they may, because of the clothes that they wear, they may be targeted. And then acts of violence. And these are direct acts of violence, as we discussed, and then these cultural, structural forms of violence that may lead to them becoming unwell. And this was similar across all settings. The Brazilian case study looked at homicide and police violence, and this was based in Sao Paulo. So Sao Paulo has about 300, 350 police homicides per year. The UK, by comparison, is about 1 or 2 per year. Brazil as a whole, 6,000, 6,500 police homicides per year, mostly young black men who are killed. So these are big issues. You know, lots of people are dying on the basis of their identity. So we then thought about what can we do? And there is no easy answer to this, except that probably interventions have to work on multiple levels. So they're the individual forms of interventions. Most of these tend to be fairly short lasting. So unconscious bias training or other forms of individual training that I've done myself. It's fair to say that the follow-up periods and the assessments and evaluations were generally not very good. So we don't know how well they worked, but most of them didn't work very well. They're the types of health system interventions. I'm sure many of you can think of interventions that may be useful. So how can we reduce some of the barriers that patients might face when coming into the health system? The ones that were probably the most effective were the structural and legal interventions, where you can change laws within a society. You can lead to these sometimes normative changes within societies. Countries set up constitutions that protect minoritized groups. But increasingly, we're seeing the opposite. We see this populist rhetoric that blames people, that scapegoats people. Donald Trump talking about, in this example, protests against Black Lives Matter movements. Narendra Modi within India targeting of Muslim people and the legal status of Muslim people compared to other migrants who might come to the country. Jair Bolsonaro talked about indigenous people increasingly becoming like human beings. He was particularly he talked about Syrian and Haitian people being the scum of the world coming to Brazil. So these are very incendiary quotes coming out from the most powerful people in the world, most powerful men, nearly always. Within the UK, we had debates around Brexit in particular, talking about taking back control from the Europeans. And we see this kind of underlying populist rhetoric, which we still see now, that talks about this other group. The cause of your problems are these other people who are coming over, taking your resources, taking what you have. When the reality of migration is that people coming over tend to improve economies and people become richer in general. So what are some of the actions that can take place? So we talked about 6 kind of principles that people need to take. And I guess it's for all of you to think about how this may play out in what you do, whether it's on a research basis, whether it's clinical settings, whether you work with community organizations. The idea of decolonization. So to go beyond the kinds of statements that people, organizations make, how can you actually value the input of others? How can you actually make sure that the populations who are most affected are at the center of the discussions? Taking a justice approach, anti-racist action linked to decolonizing actions. Can you get genuine diversity and inclusion beyond the kind of tick box exercises that we see within organizations? How do you address intersectionality? How do you make sure that people's identities are really valued and supported rather than marginalized? Can you take a human rights approach towards the actions that you see? And this can be very much at an individual level, but all the way up to the political systems that we see. Being researchers, we think about research as well. There are a number of ways which research could improve and become more diverse. We think about the populations who are supported, targeted for research. Most of the research, as I mentioned before, is US-based. There's very little from around the world on these topics. If we think about different kinds of discrimination, it's usually based on certain things, but we don't think about, there's much less research on religious discrimination, for example, compared to racial discrimination. What can we do in terms of disaggregating data so that at least we understand what the issues are, what's going on? I know that some countries actively don't do that, France as an example. But if we don't know what the issues are, we can't even begin to try to tackle them. We look at the study quality. As I mentioned before, most of these studies were small, at small sample sizes. They tended to be underpowered. They tended to have very short follow-up periods. Can we do this with in a bigger way, with longer follow-up periods? Can we get a true understanding of what's going on? Taking a life course approach, so to think about how this might affect people. In my case, I work with children and young people, how this can have a longer-term effect on their health. Then more economic studies, political studies, legal studies. If we want to change the health effects, we probably have to work with lawyers, politicians, policymakers. Those are the people who have the real, power to affect change. And then engagement with populations to really understand what the issues are from the people who are experiencing those issues. Then I just want to end with a short discussion on unaccompanied minors, as this is quite topical here in the UK. So unaccompanied children and adolescents are those who are separated from their parents and other relatives and are not being cared for by other adults by law or custom who are responsible for doing so. So my PhD student, Dr. Corona Maioli, did an overview of unaccompanied minors and their health consequences. And we found these different physical, mental health conditions related to being unaccompanied. And one of the key parts of that was discrimination on arrival, the destination country. So Susanna's work was particularly on migrants moving through Central America to the US, but this is something that happens everywhere. In the European Union, there are 220,000 children seeking asylum, of which around 20% are unaccompanied. So there's a lot of children facing this. We see within the UK, the recent UK illegal immigration bill, which seeks to exacerbate the harms. This is the hostile environment that we have within the UK, where it can exacerbate the poor living conditions, the safeguarding failures, the healthcare barriers that those children face, children who are seeking sanctuary within the UK. And I just end here with this quote. This is by Amy Stevens, who published this a couple of weeks ago. So what can you do? What can health professionals do? Well, health professionals, we have a duty of care for all children. We cannot be silent bystanders to overtly health-harming policies. With threats of deportation and detention looming, we have never experienced a time more critical to deliver compassionate, trauma-informed care to children seeking asylum. But it's not enough to simply treat the child's medical condition. As trusted professionals, we can articulate the devastating circumstances these children have come from and make the case for their ongoing needs. We must challenge policies with evidence, engage decision makers in discussions around social justice, and participate in advocacy options. Our patients trust us with their stories, and our response to such a privilege cannot be passive listening. We must both hear and act. So my final conclusions, so categories such as race are biologically arbitrary, but the discrimination minoritized people face is very real. And underlying this is similar systems of oppression that happen around the world, with structural causes at their base. Racism, xenophobia, discrimination are important determinants of health. The health community has a responsibility to challenge and to address. Let's just end with a short animation we made. So standing here talking in an institution like this, it can seem very abstract. We can talk about conceptual models, we can talk about numbers, but experiences of people are very real and very individual. So we did this consultation. We have a repository on our website where people can send us audio clips of what they think racism means to them, which I'll play now.
El racismo para mí significa definir a otro como distinto y diferente a mí de una manera tal que vale menos como persona. Por ejemplo, en Chile, donde yo vivo, crecí en una familia donde el tener color de piel blanco, ojos claros o color de cabello claro tenía mayor valía, y yo, siendo morena, sentí desde muy pequeña que yo entonces era menos bonita, o lo que decía o pensaba importaba menos. En el espacio profesional también he sentido experiencias de ser definida como menor valía por ser latina en Europa, lo que hace que uno viva la vida desde un lugar de más miedo, de mayor inseguridad sobre lo que piensa, hace o dice.
Racism to me is the beauty standard that we have in Samoa. If you look more indigenous or local, people will treat you in a way that is less than they would treat a foreigner.
My first awareness of racism was as a young brown child visiting the UK. It was to feel judged or watched every time I went into a shop or boarded a bus. It was to know implicitly that I was considered to be a different category of person than the members of a more powerful majority. It was to feel that I had to be an exemplary representative of my minority group who was deserving of acceptance, and to know that I always had to be alert to my precarious position. When I returned to live in Sri Lanka, my situation was completely reversed. I was privileged to be a member of the majority, and it was my neighbors, friends, and colleagues from minority groups who lived with the very real possibility of violence that could threaten their homes and lives.
I recognize racism in our school systems, but in the form of colonialism. As a Ugandan citizen, we were colonized by the British, which means that we had to adopt the British education system. However, years after we have gotten our independence, we are still, to a larger extent, being taught with the same education structure, which to me feels just not right. To a larger extent, the education that most Africans are getting is still colonized, so it makes it very unrelatable to young people.
Racismo é que é errado a gente falar mal da pessoa só por o jeito que ela é. É muito errado. Então eu ia falar para a professora quem tá fazendo racismo, para ela conversar. E é isso.
So thank you very much. If you want to get more information about the talk, our website, Race and Health, has details about the academic work, but we also have a number of other things, webinars, podcasts, and newsletter you can sign up to and learn more about. And also, the Lancet Migration Group also has a website you can learn more about migration and the different hubs that are being set up around the world on this topic. Thank you.